It's good to see that a lot of people have stayed almost till the end. We are getting close. And of course, we saved the best for last, so we now move on to the cardiovascular imaging part of the program. For those who don't know me, I'm Venkatesh Mani. I'm part of the radiology department here, and I work primarily on cardiovascular imaging with Zahi. So it gives me immense pleasure, actually, to welcome Dr. Jeanette Schulz Menger. She's a cardiologist by training, and she's professor of cardiology at University of Medicine in Berlin from Charité. She's also part of the Experimental Clinical Research Center, and she's been in the field of cardiovascular imaging for over 15 years, and she has more than 120 publications related to cardiovascular MR, so it is indeed a pleasure to have one of the leaders in the field come here and present to us. Not only is she an excellent researcher, she's also into teaching and established various teaching programs in the Berlin area as well. So I'm not going to spend too much time talking about this, but have her talk about emerging applications of cardiovascular MR at 70, hype or hope, and I think it's going to be a wonderful talk.
Ladies and gentlemen, thanks for that really kind introduction, and especially thanks to the invitation, because I'm really impressed, and it's a great opportunity for me to see that place here. And that's not only due to the reason that I really know Zahi for years, and I'm impressed what he could make based on cardiovascular MR, but the reason is also because I really think you are just in that place. I really enjoyed to read that overview, that review article as written by Joe Los Calvo, that is a editor of, he is heading, that's the editor of Circulation, and he wrote that report in Circulation Research. And I think that it's all about that, what we are doing, about clinical research and about clinics, you know. And it was already mentioned today, it's great to have high-impact journals based on genomics, proteomics, metabolomics, and it's really important to do the research there. But on the other hand, there are we as clinicians, and we have to define the phenotype. And we have to go deep into that, and very often it's somehow based on a stethoscope, and of course on different imaging modalities. And to my opinion, that's just the point that we have a chance to close that gap, and that gap is very often very, very large. And we can use imaging, and not only imaging itself, but also all the kinds of metabolic imaging. And to my opinion, and that's not what I have to talk about that, especially that combination of PET-MR, so going into really a metabolic imaging will give us a chance to bring that together. And also, because when you will start with 7 Tesla, you will at first be very disappointed. And I want to give you a look back. We were really somehow the crazy kids on the block when we started in that time with cardiovascular MR, because it took us just really nearly 10 minutes to get one cine like that. But it worked out. And it was a little bit later, so 2 years later, then breast holding was possible, and we were impressed by the image quality that time. And 10 years later, nobody would be astonished when I would say, that is the cine imaging I would expect just now, with a breast hold within 11 seconds. And you should never forget that when you start with 7 Tesla, because nothing will be like that as you will expect that. So you have to start again, but you can just do it. And that is that, and I'm really proud on that, what we get in a routine fashion just now at 7 Tesla. Because here again it happened that when we said in 2007 that we want to apply for 7 Tesla with a focus on cardiovascular imaging. You know, at that time I was not only the crazy kid on the block, I was a female cardiologist, and all the physicists start to approaching me and ask me, you want to do cardiac at 7 Tesla? It will never work, it will never run, they told me. And thanks to the help of the engineers and physicists, and that I want to focus on, you will never be able to do it as a clinician alone. You really need them, and it's a great collaboration. But then just now it's really working that we see images like that at the 7 Tesla, and I hope that most of you recognize that. That is just the left ventricle, left atrium, right ventricle, right atrium, and you really see details. And that is the next point. Just now we see details and how to interpret that as clinician. What every time happens when imaging modalities get better and better, we see new structures and we have to know, is it a pathology? Or is it more just now that we see more details and that we have to learn? So to my opinion, that at first, we have to come up also with clinical question. What is missing just now? What do we need to handle our patient? And then we should start a good communication to each other, to the experimental, to the physicists, to the engineers, to went into those questions and to go into those questions. And that was a pioneering work of the Minneapolis group. Camille was already mentioned. They published that first. That is just working in the heart. And they got images like that, and these were the first coils they developed. What is happening at 7 Tesla, you know, and you know it already from 3 Tesla, I would expect that sometime we have a problem with the ECG. And we are not a real-time method, so we need that kind of triggering. And that was also published nicely, that the ECG really has significant interference depending on the field strength. And believe me, at 7 Tesla, you have an ECG like that. That's not the fault of the ECG. That is just the reason that you have flowing blood. So that is a so-called, and I trained a lot to name it, the magnetohydrodynamic effect, MHD effect, and you have it. So what happens when you use the ECG, sometimes it will work, sometimes it will not work. But there are other methods around, and they are really working fine. And we were lucky enough that the head of that experimental ultra-high field facility, that is Professor Thoralf Niendorf, and Thoralf is an MR physicist. And already years ago, once he called me, and we did not know that we will sometime work together at a 7 Tesla, and he told me, you know, there is that crazy stethoscope you are using as clinicians, and what about the tones of the heart? And what he developed, that is really just using the effect of a stethoscope to follow the tones of a heart, and then to introduce that as a triggering. That means you really take acoustic triggering. That is really like a stethoscope. It's very easy to place. You put it on the heart, and then you get a nice triggering. And that is working in 99%. Interestingly, it's also working at 1.5 and 3 Tesla. But at 7 Tesla, that's really crucial, and we don't use another method at all. And believe me, the placement is easy. You have only one electrode. Never forget, of course, that is not the way to monitor a patient, so for safety reasons. But on the other hand, nobody of us is thinking about that. All the vendors did not make their ECG safe for really monitoring the patients. So we also would need another monitoring system. But for triggering, that's really the best we have just now. So that's solved. The next point is, when you want to run a 7 Tesla, cardiac 7 Tesla, then you have not a chance just to buy ready coils. And that's really interesting. All those groups, like Minneapolis, Berlin, or all the other ones, the Leiden group, they're just now really working hard to develop new coils. And that is somehow like a contrast, that you have a lot of coils. All of them have a different design. Just now they have different channels. Just now the Berlin group is with 32, and they have a new modular coil design. And what also is not more than the truth, that it takes a lot of time to develop and to make it MR safe, but that was working fine. Just now they have an ongoing approach, but it takes time. And when you then want to produce, or when they want to produce a second coil, it may happen that it does not work like the first coil. Yeah, so that is really, never forget that, experimental setting, and it's a big effort what they have to do to run that. If you go to the large companies like Siemens, Philips, GE, Rapid, whatever you want to say, they have huge teams just checking the quality of the coil. So that's completely different. And what I also have, you know, you have in the 7 Tesla, you don't have a volume coil in. That just transmits sense by the coils itself. So it's completely different. And we talk about homogeneity and all that crazy things, that nice black holes you want to have, you not want to have in your region of interest. But so you need a setting or a collaboration to handle those coils. And as I said, there are different possibilities. What I want to say is also already with our 4-channel coil, we get nice images. So it's working with those crazy coils. That is a design, and that is somehow really nice. There are 20 or 30 PhD students building all the time new coils. That is really, for myself, it's crazy. I'm a clinician. But believe me, that's helpful if you come up with your own ideas or, for instance, use the help of others. So the Essen group, that is especially Mark led, together with Harald Quick, they used another design of a coil, and you see that the results of the images are nice as well. What you are seeing here, the coils are not flexible like we know from clinical imaging. So it may also happen that, of course, the patients say, or the volunteers say usually, it's not ready to go for patients just now, that they don't feel so comfortable with that. But as I understood from the physicists, it's really important to have it such in a stable design, because otherwise there is somehow a phase shift, so they can't stabilize that. That's just the point. The Leiden group, I'm sorry, that's so bright here, but hopefully you see it. That's a loop. That is the design of the Leiden group, and that looks very smart, but just now they are not so happy with that, because it's really only a very, very local coil, so it's hard to cover really the whole thorax. On the other hand, I really love that, because they again stepped into the coronaries. Interestingly, you remember the older ones? Are here any? That when we started to image coronaries, 1.5, 3 Tesla, we every time started with the right coronary artery, because it's so easy to assess that. And here it was the same. But again, it's just working. And it was not worse than 3 Tesla. So again, cardiac MR is working. When we started with 7 Tesla, we thought at first we have to do our homework. We have to show that it's running in an easy, reproducible, robust way in volunteers, and we started really with the assessing of the boring left ventricular function, because it's important to know, does it give us the same values? Or do we have to tell the patient, when I bring you to the 7 Tesla, I have to run on top a 1.5 Tesla scan to know something about your ejection fraction, about your volumes. And that message talking about the volumes, that is saying something about the power of the heart. So I just need it. And what we did, we've compared it with different slice thickness, and the best was, compared to the gold standard as used by 7 Tesla, that we had with a 4-channel coil. That was the very beginning, that resolution, and that was really great and was working really fine. So that was the beginning, and we were happy to go with that. Luckily, the collaboration of Oxford and the Minneapolis group came out with the same, because that's really terrible, to my opinion, in research. If there is only one group showing something and no other group is able to reproduce it, then you should be a little bit skeptical. And what they also could show, they used not only the flash-based cines, all those images you saw until now are flash-based, they also could show that also SSFPs are working at 7 Tesla. And we were really astonished about that. You already know about SSFP at 3 Tesla. That's a challenge itself. So you have different possibility to step into cine imaging. But what I love to say at that moment is, as a cardiologist, if I want to run cines, I can use an echocardiography. Here the image quality is much worse, really bright here. But of course, when I want to go into the left ventricle, I only need the echocardiography. Of course, maybe the apical region is better by MR, but believe me, there will be no cardiologist you are able to convince to use MR if you talk only about cine imaging. So that can't be all when we want to use a 7 Tesla. And what I personally love with MR, to my point, that is a unique possibility we have with magnetic resonance imaging, that is that we can differentiate the myocardial tissue. And we are talking about that over a long, long time period. It's very established to show the scar itself, to assess viability. It's robust, it's fast, nobody will be astonished of that. Other late gadolinium enhancement sequences, in other diseases, you have a focal fibrosis here in the heart, and in that special disease, that is something related to the risk. You will not be able to image that with another modality. That is all done by based on 1.5 Tesla. You can see small bleedings in the heart, like here, a young woman with a myocardial infarction with normal coronaries. completely normal coronaries. And what we as cardiologists often forget, that it's not only atherosclerosis, they also may have emboli. And that is only MR being able to visualize that, and that it's a difference for the prognosis of that patient. And the only modality being able to show myocardial edema as a sign of an inflammatory process, that's MR. And here in T2 weighted images, here you have that bright signal in a myocarditis, and here in a myocardial infarction. And that was MR giving us the chance to see so small fibrotic areas like here in a myocarditis. There's no other imaging modality. So that is possible at 1.5 Tesla, at 3 Tesla as well. And of course, that kind of, or that tissue evaluation, that is also that what I want to get with 7 Tesla. Of course, I don't want to reproduce all what we already have at lower field strength. So we need different questions and different solutions. There is one interesting other point, and that is the only point until now cardiac MR really changed the world and the outcome of the patient. And so far, that Dudley Pennell's group from London, they could show that in patients with preserved normal ejection fraction, they were able to quantify the iron overload using T2 star images. 5-minute scan, 1-minute evaluation. It's really fast. And interestingly, they could show, with the help of that bars, here you have the death from iron overload, that red bars. And you see at that time point, it changed completely in United Kingdom. And the reason was, here, they introduced in all patients with thalassemia, and they have a lot there, that T2 star scanning. They had to go there. And then they started a therapy only based on the T2 star scanning. And you know, that is really amazing. And that is just not true in a lot of Mediterranean countries. Usually people start to say, okay, thalassemia, that's not so often the case. But we are talking about iron overload. That means iron overload you have also in a lot of other diseases just now. So you can really use it to change patient outcome today. And that is somehow the dream I guess most of us have. That is ex vivo, that's a completely different story. But what I want to say, and we know it from brain already, with 7 Tesla brain, you see structures in inflammatory diseases. That's crazy. That's so great. We really experience new things. And I really hope that we can also make that possible based on MR. That is, of course, not that what we can offer just now, but that is that where we want to go to understand more about anatomy, about physiology. And when I say I want to go more into the details, then it was that one of the very first CINIs Fabian Hetzel from Thoralf Niendorf's group did. He used the 7 Tesla and the chance to increase the temporal and the spatial resolution. And that is the senior of T2 star. So what he's showing here, that is a myocardial oxygenation of the blood. Of course, you know, you see all our problems we have. That is not that was a healthy volunteer. So he had not the problem that here was less oxygen. We know it from the bold imaging very good that there is a great cardiac vein. So we have susceptibility there. But the story is you really see a beating heart and you have the chance using 7 Tesla to quantify in a beating heart the iron overload, as I said, and the myocardial blood oxygenation. And that's all about that. Because then we could avoid the contrast application in patient, maybe also the stress application we are using just now. That, to my opinion, should be a way to go. I'm sure it's a long way, but maybe we are more close than I expected 1 year ago. 2012, Fabian could publish his paper, and what he could show, here you see again the T2 star mapping. You see it in the systole and in the diastole. And if you see that region here, then you have the feeling that there is a different oxygenation in the different regions of the heart. So there is a different endocardial, that is the inner zone and epicardial. When I saw that, then I told them, forget it, it's partial, these are partial. that it's really close to the cine. And what they then really did, they went into the details, run an overlap with cine imaging, they repeated measurements, and they could show it again. Nevertheless, I was really skeptical, and I talked about that during ISMRM, and then went up and told me, that's really interesting for him. Then just 20 years ago, he tried to run spectroscopy in patients like that, or in volunteers, and he experienced, and that was hard due to the spatial resolution, that there is really a different oxygenation, a different metabolism in the more endocardial zone and in the epicardial zone of the heart. So that may be the truth. And that differentiation, and that is something we tried to assess using perfusion imaging at 1.5, we failed. So that can be really a new step using 7 Tesla. That is one of my dreams. And when I'm just now with quantification, and that is, again, that what I think we should handle, I know about the problems of quantification, then we should go there. Because just now in the clinical setting, so at 1.5 and 3 Tesla, we tried to quantify the myocardial injuries. We are all very aware of late gadolinium enhancement imaging. Here you have the fibrosis, that is a healthy tissue, the black one, and that is very simple imaging. And these are mapping techniques, T1 mapping techniques, T2 mapping techniques. Just now they are showing the same, the focal injury. Also in patients without myocardial infarction, here with a fibrosis, a native fibrosis and a special kind of hypertrophic cardiomyopathy. So we are able to quantify it using mapping techniques. Nevertheless, at that point you should say, if you see it now as with just imaging, why to use mapping? But the story is different. I'm sure that we need in cardiology quantitative methods, because we have some diseases with a really homogeneous injury, like development of fibrosis in different diseases. And that is what we really need. We want to have an assessment of a diffuse injury. So, and the question is, and it's a hard discussion, believe me, that do we really need that? And I'm sure we need that. Back to 1.5 Tesla, back to different diseases. In cardiology, we have to do very often, for instance, with patients with valvular diseases. Here, severe aortic stenosis. Here, a patient with a special hypertrophic cardiomyopathy. Hopefully, you see here the thickening in the apical regions. But that is a usual arterial hypertension. So arterial hypertension, that is really a disease such a lot of people have it just now. And in the aging population, that is a big issue. And what we know from medical study 1,000 years ago, that fibrotic tissue in the myocardium makes a difference regarding prognosis, regarding remodeling, so the heart starts to fail. So we have to have the aim to quantify that fibrosis. There are publications from the 60s, from the 70s, from the 80s. They took just myocardial biopsies. But, myocardial biopsies at first is dangerous. And on the other hand, of course, it's again only a focal finding you could show. And nowadays we are very sure in all those patients we are able to show focal fibrosis in each CM, that white lesion that is a fibrosis, but also in arterial hypertension. Maybe these are the more ill patients, but what we need, that is a diffuse fibrosis, and therefore we need mapping techniques. And my dream would be, and that was a talk before, that then we could use another therapy. Today we have some agents, and it was crazy because I would describe it in the same way like it was described for oncology. Treating the arterial hypertension, I have substances, 10, 15 substances, 20. And I start with what I think, not really, not just in that case, but a little bit like that. It depends on the experience, but I have no measures. Usually I only measure the ejection fraction and the hypertrophy, but the ejection fraction, that is really coming too late. And we are able to differentiate the tissue, and then I would expect that the pharmaceutical industries, I know that they are working on components really acting on fibrotic tissue. So if we could give them the information there's fibrosis in, and we would apply that and could show a regression and then really an increase of ejection fraction, that would really be a helpful approach. But of course, talking about mapping, I have already a problem at lower field strengths. And there's only one of the problems, and you know it. That is that lovely susceptibility artifact. And we have it at different places. The motion correction, we already talked about that today. But it's not all. So if you have it already at that field strength, it will not be better with 7 Tesla in the beginning. But if we're sure about that and how to correct for that, then it can be helpful because, again, why I claim for mapping at 7 Tesla, I'm really interested not only in the elderly population. We talk a lot about inflammatory disease. That is a disease of the very young ones. That is a disease often in rheumatology diseases that affects young women. And the problem is that the walls are very thin. So there are often only 3 to 4 to 5 millimeter. And if I have a spatial resolution of more than 2 millimeter, my gosh, then I have 2 pixels for the wall. And that is what happens with 1.5 and 3 Tesla. And that's the reason why it makes sense to go down with the resolution and to develop 7 Tesla that way. And what I want to make clear, all the techniques I talked just now about, I would dream to have at 7 Tesla. They are free of contrast media. So I'm not sure if I really want to go into contrast media application. I think the big chance is to leave it here. And we have to do some homework, of course, because T2 mapping normal values are, of course, different with different sequences and with different field strengths. But nevertheless, that should be done. I'm happy also to show you a work of the Oxford group, and I guess that you know that traditionally the Oxford group, Stefan Neubauer and all the other guys are very experienced with spectroscopy. And so nobody of us was astonished that they took the opportunity, and one would expect that it's the case, that really that was a first shot, and they gave me the slides immediately, that they just ran in volunteers spectroscopy of the heart. And what they could show that here you see the signal, that the signal here in red, it's much better. So as expected, they could show with a not dedicated coil. There is a lot of chances into development that we could really believe just now that spectroscopy will be profit from 7 Tesla. Of course, we expected that, but it's working also in the moving heart. And that is another dream, that blurry image, what I would have, because that is the sodium content of the heart. And again, you have, that was also the first shot of Thoralf Niendorf's group. Sodium and the heart, that is a story itself. But sodium itself is playing a big role in different diseases. And what we already know, that in the skin and the visualization at 7 Tesla, it's much easier. You have differences in healthy volunteers depending on age, significant differences. So maybe there's also a story about, and then you could also develop compounds like that. So again, I'm sure that you could not do that using lower field strengths. All the time I talked about the left ventricle, and that's usually for cardiologists, because cardiologists try to forget the right ventricle. And the reason is very easy. We dealt a lot with echocardiography, and the right ventricle is not easy to assess. It's much easier with MR, but nevertheless, it's very time-consuming. But we have to learn to understand it, and that really makes sense. At first, sometime using echo, and that is as a choose for all MR field strengths, you have a problem to assess the right ventricle itself if you have a thoracical abnormality, pectus excavatus, like here. It's somewhere the right ventricle. So echo is not helpful. Then we know, meanwhile, in a lot of congenital diseases, the right ventricle itself, that is a ventricle giving us a prognostic information. And we have to learn so much about that because the tabularization is so different. And he is like a chameleon. I hope the English pronunciation is right. You know that little deal? Changing all the time? That is the right ventricle. Okay. And we have to assess it to understand it a little bit better. And here again, these are common congenital And again, the assessment of the right ventricle will not be done so accurate using echocardiography. But what happens with MR is, and it's a good and it's a bad story. From the clinical perspective, it's a good story. From the technical perspective, it's a shame. When they brought the new criteria of arrhythmogenic right ventricular cardiomyopathy, a dedicated disease of the right ventricle with a high incidence of sudden cardiac death. So we need to assess it. In former times, we were very happy. One of the characteristic points of the disease is that the myocardium of the right ventricle has a lot of fat and a lot of fibrosis. And so it was very clear when we assess fat with a cardiac MR, then it's dedicated to arrhythmogenic right ventricular cardiomyopathy. But that's wrong. And the problem is that fat is bright and scar is bright with late gadolinium enhancement. So with usual MR scanning, we fail to differentiate that. And that was the reason why we are not anymore in the criteria with our tissue differentiation. And that is really a shame. For the patient, it's better because we have just now very clear definitions. We have in a very time-consuming way to quantify the right ventricle. R usually is used for that. But again, I want to get that back, the tissue differentiation, because we are the only non-invasive method to do it. And just now, the patients have to get a biopsy. Only to show you that disease, and that is really a significant stage, you see here all those small aneurysms. That is a sagittal view. And you go through that with 6 millimeter slices without a gap, and you assess it. It's really time-consuming. And the quantification is done just now in an axial view because the standard deviation is low. And here again, you see the right ventricle, and you see all that small aneurysm here. You see that very thin wall. It's sometimes only 1 millimeter, maybe 2 millimeter. And we want to go into the tissue. And I guess that is a chance, again, not 7 Tesla to do that. But that's difficult for sure. But if we make it, then it's a big step. The quantification, and that is just my request for all those running developing post-processing contours, it takes you hours to quantify that. Because believe me, until now, all the post-processing softwares are not really working on that. So there is a friendly fellow or a doctor just working on that for half an hour or 20 minutes. It really takes time, but that makes a difference in the diagnosis. So there we need a development as well. On the other hand, we are really good with it. So the standard deviation is small, and that is the reason why we use that axial approach and not the short axis view. With the short axis view, you will fail in the assessing of the pulmonary valve, and so you don't cover the whole right ventricle. But that's not the story of 7 Tesla, but the story of cardiovascular MR. So as I said, the right ventricle just now at 7 Tesla, we are really happy to see it like that. And here we also see nicely the valve. Here we have the pulmonary valve, and that is really easy to assess. On the other hand, then we were a little bit afraid, and there is not such a huge contrast between blood and myocardium. What will happen when we start to quantify that? So again, there was a nice guy who he had to quantify that. Again, we were able at 7 Tesla in a good image quality to assess the whole ventricle. And I want to say that investigations like that, left ventricle, right ventricle, a technician is scanning. And it does not take more time than at a routine clinical scanner. So that dedicated protocol with an established coil, that's important, and with that special triggering approach. And then we quantified that, and we're happy to see that we were able to use it because the differences are not too bad. And again, we use that 4 millimeter. But to quantify 4 millimeter, that takes time again. That is hopefully a step we will go sometime. That was done together with Peter Kellman at 7 Tesla. That is a big challenge, that fat water imaging at 7 Tesla. It was working, and that was the first step. And I hope we can also go sometime then into the myocardium. But until now, at that place, I talked only the myocardium, because that is somehow the focus we have. But when I met Sai first time. He's really interested, and as I was able to see today, really in the vulnerable plug, and we need it as cardiologists. And the question is, of course, what could we do with 7 Tesla there? And that is a big message. Plug imaging nowadays in human, nobody did it. But sometime, so it's a good message for you, but nevertheless, there is some nice work, and I guess that is really a hope. That was done by Harald Quick. That is without contrast media. He assessed the renal artery with a good image quality, so that is just working. And what he preferred to use, that is really a sequence like Tesla. So you will be able to assess the vessel itself. And I'm really thankful to Mark that he gave me that slide, because I saw that really 2 months ago, first time, that they really developed a flash-based approach to scan the peripheral arteries. And there is no contrast media in, and you see several steps. So the patient is just, they move the patient. You can't do it so fast like at lower field strength, because then the patient will not feel well. And the results, from my point of view, they were really impressive. So that is an unenhanced MRA of the lower extremity and volunteers. That is, again, the Essen group. And there's also one patient, so that was the very, very first patient they scanned. And here, look down here, 1.5 and 7 Tesla. And to my opinion, that's not a hype, that's a hope. That's really great. Nevertheless, when we talk about that, of course, and that's sometimes often not so easy. You have the physicists there and me by myself, and we want to try all the things, but we should never forget that there are some issues we have to solve before. And there was that main issue, what about patient safety, and that what we want to learn. I'm not open-minded to put a patient into a 7 Tesla scanner just for fun and only to look. There should be a question behind, and there is one really safety issue we had to handle, and we had to do the same years ago. And these are very funny images, to my opinion. That was with a 1.0 Tesla, there was a cardiologist really putting a lot of stents into a coronary artery. So, and that was an artifact only. And I'm talking about coronary stents. They are from metal. And we are talking about MR. And that time we put those patients in, but then we thought, is it a good idea? What do we have to know before? Because sometimes the cardiologist places 6 or 7 stents. And at that time, we organized the infrared camera, and we really measured the temperature of stents. Really, they were in the field, in the scanner, and we pushed really hard sequences on it, and we are happy to see that there was no significant increase in temperature in the stents, whereas we could show it for leads. So we feel safe, and until now, I guess most of you know that's no problem at all to scan patient with scans. And we ended that experiments with taking pictures of ourselves, and we learned why it's always called for myself. And the men were much more happy because I lost all the temperature, I give it out. But then I learned, when I asked the guys from 7 Tesla, we need to run that measurement again. And then they explained me friendly that it was a nice idea of ourselves to measure the temperature itself, but it's not only about the temperature in MR, it's about the electric field and what happens really to electric field and the relation to temperature. And then I was really thankful. They settled an experiment and worked hard on that, on a phantom, and they used the copper tube and compared that to stents, and then they learned that they can use that copper tube and really measure the temperature increase by measurement, really the electrical field, and we were lucky to show, and that is just published, that there is no significant, in that setting, in that phantom setting, in that direction to the field of the stent, that there is no significant increase of the temperature. So just now we have a feeling that in that certain setting, there is no danger as induced by a stent. Why do I say it so careful? Because a stent is usually not just in one direction. A stent doesn't care for the directions of our magnet. So it's somewhere. And just now, they really start to run phantom experiments on a model, really to understand what happens. But the first experiments of our group and also the Leiden groups, they are promising. So I really would expect that that would be solved. But in the beginning, I would be very careful to put patients with stent into the scanner, especially if we don't have a question until now where we say that's the only question, it can be only solved by 7 Tesla. So at that time point, to my opinion, we should be a little bit careful, but just now I really have the hope, or I'm nearly sure that that will work. You know, the very last slide, that is that what we can reach just now slice by slice at 1.5 Tesla. You know, we have a beating heart, green is a healthy myocardium, red is the scar, yellow is the area at risk, as characterized by an edema, and we can do it for a lot of diseases. Takes a lot of time to do that, has a certain spatial resolution, and I'm sure that we can overcome a lot of those stuff using 7 Tesla, maybe for dedicated questions. And I really think that will be, that's realistic for the next years. And in the end, before I thank you for your attention, I really want to thank 2 teams. That is the team of Thoralf Niendorf, and you see also our collaborator from Siemens. I really have to say that those work, that is Thoralf Niendorf, by the way, that work in a 7 Tesla can't be realized without a vendor at that time point, to my opinion, and we have really a great research collaboration here. And I have the same experience with my own group, that is a clinical group, and there are meanwhile a lot of people in, and you know, there are the questions coming from. Every time when they say, I have no idea what is going on in the hospital, what can we do, then really we have the new questions, the new ideas, and that is the way how it's going. And I hope it will go on that way, and wish you the same, and wish you the fun, and wish you the success, and I'm sure you will have it. Thank you.
You this appreciation thing. This is for the poster guy. Okay. Are there any questions? No. So sorry.
So Janet, maybe to re-emphasize, in a sense, what you have said, and you as a practicing clinician cardiologist, where do you see, you know, the greatest impact of 7T, knowing that obviously, as you said, you know, you have already some solutions at 1.5T and 3T. Where is really the biggest, you know, impact that could have clinically?
Of course, currently I could only speculate on that because I don't know what can be realized by the engineers, by the physicists. But I really see it as a chance that we will have better spatial and temporal resolution. Usually we have to decide somehow, and I really, for instance, want to go without any contrast application in a quantitative assessment of small structure. And when I get that in a robust way, then we will bring it again into outcome trials. So I really believe in that T2 star. For sure, spectroscopy. Of course, we say for sure since 20 years now. And really, I hope that the plugs will make it.
Any other questions? All right, thank you very much. Okay.